All right, no problem.
Okay, so let's start with traps.
Okay, so if we start with traps,
Starting.
bilaterally, if for a smaller practitioner, if they're gonna do bilateral, no big deal. Start an extension in the cervical. We know that it's most superficial. A superior traction or inferior traction, extension to flexion. Unilateral, which we want on the test. Unilateral, a little bit of rotation, ipsilaterally, flexion, and you can rotate away just a little bit as well. Okay. Splenius. Splenius, we know that it goes superior, lateral, fiber orientation up to the lateral superior nuchal line and mastoid process. So if you're around C2, C3 when you do it, we know that we can rotate ipsilaterally, extend, take your superior lateral tensioning. It's a little bit deeper than traps. Rotate and a lot of flexion. Flexion with a lot of rotation. With superior lateral tensioning.
So flexion with contralateral rotation.
Yes. Semispinalis. It's basically just lateral to the spinous process. Extend, flex. If you want to split hairs, put a little rotation in at the end because of the medial fiber orientation. Okay? Masseter. To landmark it, make sure that they clench their teeth. That way you can feel it. Get them to relax. It's superficial underneath this, basically the cheeks. So you don't need that much compression. It also hurts them. So enough compression and tension that you're affecting. Get them to open the jaw to lengthen.
So if you were to indicate, like, let's say TMJ, would you be hearing like a popping sensation?
Popping, jaw tracking sensation, like with her.
Deviation, deflection.
Watch her jaw as she does it.
Hers is
Clicked, and deviated to the left, and come back, and then it goes to the right and back. So there's a tracking
Lateral
issue there,
deviation.
and there's a popping, clicking when she's opening and closing her jaw.
Your
Temporalis.
temporalis.
So clench again because it also helps with muscle. It's a muscle mastication. Make sure that you feel for temporal artery so that you're not on the vessel. Again, superior tensioning or inferior tensioning, however you want to treat it. Get them to open the jaw. And there. Okay. SCM. SCM. Get the person to hold their head up with contralateral rotation and flexion. I'm going to take my hand away. It pops up nicely. What you want to look for is the sternal portion of SCM, the clavicular portion of SCM. The little divot in between separating them nicely. Behind the clavicular portion of SCM, anterior scalenes. So palpate for anterior scalenes, and that's not the one we're doing first anyways, we're doing SCM. So you can compress and tension the insertions. What the tutors don't want to see you do is compress the belly because you might compress the carotid. You can trigger point it with thumb and finger, you can trigger point it with 2-finger contact. If you're going to do myofascial release, contralateral rotation, flexion, ipsilateral rotation, extension, with a little bit of lateral flexion at the end. And see, on every person, you're going to feel a little bit different anatomy. Just figure out how to tension it up on each individual person. But that's the combination of movements. Anterior scalenes. Anterior scalenes, we said the sternal portion of SCM, clavicular portion of SCM. Right behind it, you're going to have anterior scalene. Contralateral rotation, flexion, ipsilateral rotation, lateral flexion.
Can you show that one more time?
Contralateral rotation, flexion, ipsilateral rotation, lateral flex away. You might notice that I'm taking it back to neutral, so I'm flexing at the top, and then I'm bringing it back to neutral. So you can add an extension if you want to say that extension's there. It's there, but I'm not extending past neutral, so I'm coming back to neutral. Okay. The next bump right behind anterior scalene, middle scalene. It's ipsilateral lateral flexion. Take your tension. Lateral flex away, or contralateral lateral flexion.
guy's got a big date, I forgot.
If you can't find posterior scalene, do the maneuver and you'll feel it pop into your hand. That way you can identify it. So we're going to do extension, ipsilateral rotation, flexion, and rotate away, or contralateral rotation. Okay. Superior oblique. Superior oblique, we know that it attaches inferior nuchal line to lateral mass of C1. We know to shorten it, we can do contralateral rotation. So palpate, mastoid, find the lateral mass of C1, come posterior to it, you'll be on the superior oblique. Do an inferior or superior tension. So contralateral rotation, superior tensioning, ipsilateral back to neutral, lateral flex away. If you feel it tensioning up and you're not exactly on it, reposition your hand a little bit more posterior. Contralateral rotation, ipsilateral, contralateral lateral flexion. Inferior oblique, spinous of C2 to lateral mass of C1. So your landmarking becomes important. We know where inferior oblique is. Ipsilateral rotation, superior lateral tensioning towards the lateral mass of C1, contralateral rotation away.
Can I get these videos on YouTube after?
Rectus capitis posterior minor major. Very close in proximity, so you're not going to really differentiate. Just know landmarking and where they originate and insert. Extension, especially C1 to C2 and C1 to CO, or whatever you want to call it, occiput. Extension, flexion, get the patient to chin tuck or you induce it yourself. Okay, so you're shortening with extension. You might want to put a little bit of ipsilateral rotation in. Come back up, chin tuck, and you can even rotate contralaterally. See if you can get a little more tensioning in there. Sit up for me. Serratus posterior,
That's okay.
superior. Sorry guys. The side you're affecting, get the patient to high five and contralaterally rotate away. C6 to T3 of the spinuses to ribs 2 to 5, just lateral to the angle. You can take an inferior lateral fiber orientation or tensioning, superior medial fiber orientation or tensioning. Get the person to breathe in, take your tension, breathe out, look at me, and take the arm down to the other hip. To differentiate between posterior serratus and rhomboids, if someone says they feel an elbow or baby finger tingling sensation, that's trigger point for serratus posterior superior, over top of or underneath rhomboids. Okay? That's
Awesome.
all.
Thank you.